So, this morning, very lucky to have Liesl, who's going to do this session on cognition and strategies that we could potentially use and apply to some of the physio interventions that we do, and also touch on probably some of the OT type interventions. Not massively, because we've got an OT coming in next Monday from the OC who'll talk a bit more about the role of OT, as well as a psychologist in brain injury rehab. So we're recording this on the lecture capture for the MSc guys to watch, so you've got to ask lots of very interesting, insightful questions and be very nice to Liesl, because I can watch it back afterwards. But I'll leave you in Liesl's capable hands. Okay, cheers.
Alright, thank you. Okay, so as Ben mentioned, I'm an occupational therapist. My background has been in neuro rehab and latterly in teaching, but also working as a brain injury case manager. So that's been quite interesting in terms of getting to know people over long periods of time. So working close with people for a number of years to understand the impact of brain injury. So a lot of this is going to be about head injury, brain injury, but obviously it extends out into any condition that's going to affect people's cognition. So what we're going to do first is we'll think about, I'll just go through the different kinds of cognition. We'll just think about it in broad terms. So I'm not quite sure the neuropsychologist is going to talk to you about it. Just in broad terms, and then think about how this might present and what are the sorts of things you might see if you're working with somebody. We'll talk a little bit about approaches and start to get to what sort of strategy training is. And again, not just so that you understand what other people are doing, but so that you can start to apply it, because some of these are very simple techniques that you could just use when you're working with somebody. So how to get the best out of them in your therapy sessions. So what I want you to do first, we're going to look at a short clip. This is a film that's available on Bob National. I don't know if you've used much of Bob National, Bob's box of broadcasts. You can get it up on Moodle. And it's a short clip from a film about a guy called Simon, his experiences of his brain injury and his recovery. And the lovely thing about this is it's his OT. He's out there with an OT. So I want you to, we're going to watch the clip. It's only 5 minutes long. And I want you to think about what is it when you're working with somebody that you need from them in order for them to be able to engage with you and to benefit from your interventions. Okay, and then we'll draw on some of that through the rest of the session. I have to sign it. Hi, it's okay, come sit down, it's fine. Okay. So just going to watch a 5-minute clip. This is Simon. You're seeing him at a point when most of his kind of movement difficulties have been, you can still see that he's got problems with his movement, but he's resolved a lot of those. So we're really now starting to think about the cognitive and behavioural changes that are coming from his brain injury. So I hope we've got sound.
This is me before my accident. Can you remember who were in that photo? Not really, no. This is me in a coma. I look like a mess. And that's me now. I want to get back to being like this. But here is an old bloody brain injury. In this one, I do.
Where are we going now then, Simon?
Across the road.
Okay, which direction are we heading?
No.
Can you just get your bearings for a minute? Have a look around and see if anywhere looks familiar. That way, okay.
Right. I'll see that one.
Simon is 20. 6 months ago, he was on a night out with friends when he fell from a 20-foot wall and suffered a massive brain injury.
Oh no, there's no more baskets.
Okay. What should we do?
Get a trolley.
We could get a trolley, yeah? Just have a good check around to make sure
Oh,
first.
there's loads there.
Simon should be at university in Newcastle. Instead, he's under the 24-hour care of a rehabilitation unit.
I forgot what we were looking for. Oh, chairs. Are they that way? No. Are they down there? I've forgotten what I'm looking for.
Okay.
I wanted to remind him it was a chicken Kiev he was after, but I was told not to help.
Oh, there's chicken meat. I've forgotten. I've totally forgotten. It's gone.
I just wondered, Simon, how you thought that went.
I went absolutely fine.
Is there anything that you found difficult about the session you just had?
Nothing at all.
Nothing at all. Is there anything you'd like to do different when you go next week, for example?
Don't get nervous.
Okay.
I first met Simon in hospital. It was 3 months since he'd woken up from being in a coma. Can you remember who I am and what I'm doing?
Zach. I used to be working before. And I've had a documentary on my brain injury. It happened in Newcastle where I'm at university, but I have no say in that.
What do you mean you have no say in it?
Well, I don't know what happened in Newcastle and why I couldn't be at home. These things. I don't think I'm someone which is surprising. These.
Why are you showing me those?
Because otherwise it's going to have an accident.
And what we're seeing on Simon's scan is that the main injury has been the frontal lobe banging against the inside of his skull here. So he's either hit himself like that on the front or hit himself like that on the back. And the brain has moved within the cranial fault, is impacted here, and now he's got bruising and swelling in his brain on the front inside his skull. You see a tooth shot off at that moment.
And the cameras are linked. Again, I don't know what got them, but it helped.
His memory is poor, his concentration is poor, his ability to plan things and get himself organised is hopeless. It's just out to lunch. Simon, the person, doesn't actually exist at the moment. The old Simon, he just isn't there. It's physically him, it looks like him, it sounds like him to a certain extent, but it ain't him.
Oh, Mum's it.
Okay.
And how did they know when you were coming?
No, I come every day.
The question we get asked every time with anybody who comes into the brain injury unit is, how good is he going to be, Doc? Is he going to make a full recovery? When's he going to make a full recovery? And we always deflect that. And we deflect it because we really don't know.
Did you find it alright?
Yeah, well, I've been here every day. It's fine.
Despite the uncertainty, Simon and his mum Jane agreed to let me film over the next 6 months as they began to discover how much of the old Simon would come back.
So what I'd like you to do, right one, is just turn to your neighbour just for a couple of minutes and think about partly what you saw with Simon, but when you start working with somebody, what is it that you need? What do they need to do in order to be able to benefit from physiotherapy, to engage with you? So just come up with a quick list of the things that they need to be able to do. Okay? Okay? Natural love. So, what is it that the person needs? Just shout out some of your ideas. What do you think they need to be able to engage with you as a physiotherapist?
Insight into their injury and about their abilities.
Yeah. So, now we talk a lot about insight. What we actually mean is awareness, and we'll talk about awareness later on. Yeah. So we kind of have this idea of almost like a global level of insight, and in fact, awareness is patchy, so they can have good awareness in some areas and not in others. So, but yes, very important. Because if someone hasn't got their insight or their awareness, what is it that they might not do? What are they going to struggle with?
They might not engage in it.
Yeah.
It's not a problem.
What's the point?
No.
There's nothing wrong with me. Why do I need to see a physiotherapist? Yeah? I can ride the bike. I remember one of my clients, coming back after with another black eye because he decided when he was at home, there's nothing. Of course, he could ride his bike. Got back on his bike after a brain injury, ataxia, and a leg length discrepancy, and of course just fell straight off. Couldn't save himself because his righting reactions and protective mechanisms weren't working as they should be, and sort of landed on his head again. Yeah. Or the same one jumping into the swimming pool ahead of me because I can swim. So I've watched him sink to the bottom of the pool. And that then brings on issues about safety as well. Anything else? So what other things do they need?
A way of communicating.
Yeah, so they need to be able to communicate with you, and they need to be able to understand what it is that you're trying to get them to do. So we're not even going to talk about communication difficulties today, but it just in terms of processing information, you need to be aware that people's ability to process information may vary dramatically according to the cognitive functioning. Okay. What else?
Trust, they need to be able to trust you. Like you need to get like a rapport,
Yeah.
like a relationship.
Yeah. And I suppose some of that might come into awareness, that if they don't have a problem, then why do they need to see you? They might mistrust you because you're giving them messages that clash with their view of the world.
Would you also need to make them aware of their kind of limitations, what they can't achieve? Could they be over ambitious as such? So you need to temper that.
Yeah. So that kind of, and that of course might affect all of these. If someone doesn't know that they've got difficulties and you're trying to slow them down a little bit, then that might be difficult for them to take on board. What about the learning process? Because do people learn things, do you think, when they're seeing a physio? Yeah. So what about learning? What did you see from him that clearly he had difficulties in that are affecting his ability to sort of keep track of information, to know when his mum had seen him last?
Memory.
Yeah, so he got quite bad memory difficulties. So if someone's got memory difficulties, potentially that will have an impact on your intervention. And we know that if people have cognitive difficulties and they have movement difficulties, that the outcomes can be worse. It is harder for them to benefit in the same way. Okay. Anything else anybody wanted to add? There are lots of things we'll talk about some of them. So some of it as well, which would kind of, I won't touch on massively, are things like motivation. So we need to, particularly if you're setting exercises or home exercise programs, you're relying on somebody's ability to remember to do them and to be motivated to take part and to participate. And we know that apathy is quite a common consequence of brain injury. It's not a cognitive difficulty per se, but it can be a common consequence. And also things like stroke can cause apathy as well. I know that you haven't been out on placement yet. Has anybody experienced working in the health service? What happens to the patient that doesn't turn up to their appointments? If you've got outpatients, what
Don't
happens?
they get like a black mark? And then this is what I was told. There's some sort of policy in place that if you don't turn up and you don't tell them beforehand, you get in trouble basically.
Yeah,
and then they don't like, you go down the list of priorities.
Yeah.
So I've heard.
And you might, well, quite often you find that people get discharged. You know,
Yeah.
they might be offered one appointment, they don't turn up, one more, and then they're out. Look, there's lots of places that have that policy. And when I worked in the community with people with brain injury, we would quite often have people who had been discharged, and they're discharged because they're so cognitively impaired that they can't keep track of everything. And yet, so the most vulnerable people are the ones that don't get the services they need because they're not able to follow and jump through the hoops that we set them as a health service. So. Okay, so this is a kind of way of thinking about cognition that occupational therapists use a lot. Your average neuropsychologist would see this and hate it. It's not. It's somewhat misleading because it makes people think about hierarchies of cognition, and we know that cognition isn't organised in a hierarchical way. It's much more of kind of systems, network based. But it's quite useful in terms of chunking different areas together and understanding how they might possibly impact on someone. And quite often, the bottom layers like arousal and orientation are the more severe. So when people have got problems with arousal and they're very disorientated, then it's more obvious that they've got more significant damage or more significant cognitive changes. And executive function we'll come to last. You can have reasonably intact all of the others, but executive function can be damaged, and that can have massive implications on people's ability to then function in everyday life. And that can be more common in the walking wounded, so you kind of might not see those as much because they tend to have less motor problems, but it's more common with people that have those sorts of head injuries where they don't necessarily get admitted and then they just are left to their own devices. Okay, so we'll work through them to understand what it is you might see and how they're going to affect the person that you're working with. So arousal is really just that, it's your kind of level of awakeness and alertness, if you want to kind of think about it in those terms, the sensitivity of the system to the environment. And so you can be minimally responsive, so that's like hypoarousal, and that might happen when somebody's in coma or coming out of coma. And you can have hyperarousal, which is hypervigilance, and you might have that when people are in heightened states, with anxiety or post-traumatic stress disorder or on some kind of drugs and medication that will cause hyperarousal. I'm not going to get into the sort of neuroanatomy of it, but levels of arousal are really important because they affect learning, and they also affect the person's ability to engage with you and to make sense of what it is you're doing with them. So if you think about arousal levels in general, what are the kinds of things, just from your own experience, what is it that affects your arousal levels? What is it that kind of makes them lower, and what is it that makes them higher? Any ideas?
Caffeine.
Caffeine, yeah. So caffeine is a very common strategy, so to kind of get your arousal levels higher.
Sleep.
Yeah. So sometimes too much, sometimes not enough sleep.
Exercise.
Exercise, possibly, yeah.
It makes me feel more awake.
Yeah. You're not supposed to exercise before you go to bed, are you? Because it wakes you up too much. What else? Anybody unwell today? What happens if you've got the flu or you're not feeling very well? Depending on the illness, sometimes you can start to fatigue more and you find that your arousal levels start to drop. What might you see if somebody is, has low arousal levels? What might you see them do? Any ideas?
Start looking up out the window or something, or disengage with what you're doing physically.
Yes, they might start to disengage. The looking out the window might be to do with the next thing we'll come on to. Yeah. So they might seem to be drowsy. Yeah. They're not responding very well to your instructions or to your voice.
Irritable.
Could be very irritable, yeah. If somebody is hyper aroused, then you're more likely to find that they're going to be jumpy, irritable. They will have difficulty kind of attending to what they're doing and staying focused. When somebody is kind of in a lower arousal state, what you don't really want to do is go in and turn all the bright lights on and shout at them. It's not a good idea. They get very irritable, and particularly in the early stages when people are recovering from brain injury, their arousal states can be quite low, so it can be quite difficult to engage with them. And if you're too bright and breezy, you're more likely to sort of get a negative response from somebody. But it also, arousal then will affect people's attention levels and they'll affect their memory as well. So their ability to kind of take on board what you're doing in those early stages is going to be quite limited. This was just, it just refers to that idea of a bell curve really, of a normal curve in terms of the way that arousal levels change. What this is referring to that is as you kind of become more stressed and your arousal changes, then your performance starts to change as well. So your performance is lower at the beginning when you're under aroused, and it deteriorates as you become over aroused. So there's sort of an optimal level, and you'll recognise that for yourselves. You know, some people really like exams because they need that level of arousal to get the brain working, to get their adrenaline running. And other people, actually, their ability and their performance deteriorates significantly because they're too aroused at that point. But what this tells us is that, when you're working with people, you need to be thinking about how much pressure and how much stress you may be putting somebody under with the things that you're trying to get them to do. So it's about getting that balance right, really, with how far you might push somebody, don't mean physically, how far you might encourage and motivate someone before it starts to tip into being a kind of detrimental strategy. Orientation is fairly reasonably straightforward. So we'll talk about being orientated in time, person, and place. And you'll get problems with orientation when people are confused. So when they have delirium, for instance, so people have acute infection or might have meningitis, or there might be a whole range of reasons why they're delirious. And it's associated also with amnesia. So in the earlier stages, when people have amnesia after a brain injury, you might find that they're quite confused and disorientated. So they might be particularly disorientated in time, not knowing what time of day it is, not being sure about where they are, so they get lost on the unit because they can't keep track of actually where they are in place as well. And so particularly with brain injury, you get more of the temporal lobe damage, which results in disorientation in place. And it's partly thought that the temporal lobe is associated with lots of memories, so there's that sort of filtering process. So normally, you get that sort of feeling of deja vu, or that sense that you've been somewhere before, and we can kind of filter those out. Well, there's a thought that actually after brain injury, that mechanism is damaged, and so people can't distinguish between the memories that they're being bombarded with and the reality of where they are. And so they get quite confused about where they are in time and where they are in place. So if somebody's confused, how is this going to affect your ability to work with them, to engage with them? What kinds of things might you see? What might they do?
Take an example from the film you just showed. You didn't really know where he was going. It's like didn't really recognise the street. He was like, right, I know that way, but go across the road. So orientation was a bit off. Yeah.
So he's sort of his map building skills, and it seemed like been there before. I'm assuming he'd been there before, but he couldn't orientate himself to the environment very well at all. So, and actually some of those orientation problems can continue for quite a long time, which can be misleading. So when you're working with people in the community, you suddenly find that someone gets lost. You think they're okay out in the community, in their local area, and then they get lost, or they end up somewhere where they're not supposed to be, because there's still issues with their orientation. So it's thinking about things like being able to find their way. If you work in an inpatient unit and you want them to meet you somewhere, if they're coming to the unit, will they be able to find their way there for a start? If they're confused, then they're going to have difficulties keeping track of when they saw you, where they saw you, what did they do. So that kind of carryover from one session to the next might be more problematic. So some of your intervention is going to be grounding them when they start to see you about who, they might not be aware of who you are. So if you see them from one day to the next, they may have no kind of recollection of who you are, what you're doing, when you last saw them. So it's sort of kind of grounding people into who you are, introducing yourself, what's the purpose of what you're trying to do with them, trying to draw links with them from when you saw them last. So you're constantly sort of prompting them in terms of their orientation. People can become quite agitated though if they're really determined that they are somewhere or something is happening, and so it takes your kind of therapeutic skills to help them to calm down. Sometimes continually telling them no, you're wrong is not actually the right thing to do. So it might be listening to somebody's distress and listening to them and trying to find out what it is that they need. Might be a more appropriate way of dealing with them if they start to get agitated. Okay, right, we'll watch another little clip about attention. This is just for fun. You might have seen this before. I think they used it as a cycling advert. Here we go.
This is an awareness test. How many passes does the team in white make?
Have you seen this before? Oops, hang on.
The answer is 13. But did you see the moonwalking bear?
Did you see a moonwalking bear? The clue was in the top corner, wasn't it? Did anybody not see the moonwalking bear?
I didn't see it.
So it's just a very simple demonstration of the power of attention, really, and how easy it is to be distracted and to miss things. So attention, really, we talk about attention being the powerhouse of the brain, but there's these different types of attention, and they can be quite important, because sometimes we talk about people having poor concentration or being distractible, but it's important to understand which part of their attention may or may not be working, to know how it might be best to facilitate their attention. So we talk about these different types. We've got kind of focused selective attention. And that's when you're in a party, you're in a bar, and you're trying to listen to somebody talking to you. So you're filtering out everything else from the background, and you're focusing in on that particular conversation. And that's just selective attention. Sustained attention is the most obvious one, and that we kind of think, how long can you concentrate for? So it's that, how long can somebody actually focus on a particular task? So often what we're doing in a lecture situation is that you're working on sustained attention because you're trying to focus on one particular thing. I've got one. Oh no, I haven't. Dividing your attention is really when you're doing two things at once. And so for most of us that might be things like, you might be cooking and you're on the phone at the same time, or you're trying to make tea toast at the same time. So you're doing two tasks at the same time. And we know that with multitasking, that, for instance, when people have motor difficulties and they have brain injury, that all of their motor skills require a much higher cognitive load, so they're more cognitively biased and less automatic than they were before the brain injury. So when you're trying to get someone to do something multitasking, so it might be as simple as walk and talk. So if somebody's walking and talking at the same time, that might be enough then to affect their attention. And you might find that actually people fatigue very quickly, and they get a mental fatigue, cognitive fatigue very, very quickly. So the people with brain injury, I'll talk about fatigue a little bit later on, but they often describe this process where they sort of hit a wall and they can't do anything else, and it's all related to mental fatigue rather than physical fatigue, but you can trigger mental fatigue through physical activities. So, you know, taking somebody's walking around the shops, for instance, that may be enough because there's so much processing that goes on with that to really trigger off mental fatigue. And then switching and alternating attention is that, you know, you're cooking something, the phone goes, you go away, you answer the phone, talk to somebody, you come back and you pick up the task where you left off. So divided is where you're kind of doing two things at once, and switching is where you sort of focused on one, you have to move your attention to something else and then you come back again. And so what often happens is, if you've got working with somebody with attention difficulties, if you interrupt them in what they're doing, they might have difficulty picking up where they were. Okay? So you might think, oh, I just need to tell them something, I'll just tell them about the next appointment, and that's enough for them to lose track. So they've kind of lost what it is they were doing and where they were at. Field-dependent behaviour, this is really about people become distracted by something irrelevant. So it might be that, you know, if they're standing at the sink and they're trying to wash their faces and brush their teeth, that they get distracted by the light switch. And you sort of see perseveration with that, so they might actually get stuck on one aspect of the task and repeat it over and over and over again. So the reason why attention is so important is because it affects people's learning significantly, and it affects their memory. If you can't attend to something and process the information, then you're not going to encode it and develop those long-term memories. And attention is very sensitive. So if you think about fatigue, yeah? So in the early stages of rehab, people tire very, very quickly, and they might tire quickly physically as well as mentally. So fatigue is going to affect their attention. Once somebody's lost their attention and they've hit that kind of wall, you need to give them a break because it's not going to come back on its own. You know, and you can recognise that in yourself. These are the same mechanisms that you have. So, you know, once you've got to that point where you just can't concentrate when you're reading, there's no point in continuing to try and read, is there? You've read the same page 4 times. It's your brain's telling you that it's had enough, and you just need to stop, do something else, and come back to it. So it's the same sort of thing. So you might be thinking about, actually, how long am I going to see this person for? How much information can they take on? Maybe I need to shorten my intervention, my therapy sessions with them because of their attention. The other aspect of attention is that it's sensitive to the environment. So that becomes absolutely key. So we talked about selective attention. If there's a lot of noise in the background and the person has to filter that out and focus in on you, they're going to fatigue very, very quickly with their attention. So that it becomes paramount for some people that the environment you're working with them in is quiet, doesn't have lots of kind of visual distractions, yeah? So that they can focus in on what it is you're trying to do. And that might determine actually where you see somebody. You know, somebody's got lots of attention difficulties, seeing them on the ward, for instance, an inpatient might not be the right place. They're noisy, they're busy, there's a lot going on, you don't have a lot of space. That might not be the best place to see someone. And so attention deficits are very, very common with all kinds of brain injury and with stroke, particularly in the early days. And the other thing that's important about attention is that the complexity of the task. The more complex the task, the more the attentional demands on it, on the person. So you really need to, you know, thinking about grading the task down to a level in which the person is able to cope with it. So you might be dealing with their mobility, for instance, or their arm function, arm movements, or balance. But actually, if it's too complex, then it's their attention that's going to interfere with their ability to benefit from what you're doing. And the task should be familiar. So the more familiar the task, the easier it is. The more novel and complex, the more difficult the task is. So it's just being kind of aware of these things when you're working with people. So if you're working with somebody and they have attention difficulties, what are you going to see? You already said, they might drift off and look out to the window. What else might someone do?
Fidget, move around.
Yeah, so they could be fidgeting and moving around. You see that in kids, don't you, as well, when they're it's sort of a sensory processing, trying to stimulate the system. Yeah. What else might you notice?
Change the subject. So you're talking about something that you want them to do, and then they just change the subject. I notice a lot with children when they don't want to focus on what you're saying. They change the subject completely. Yeah. Like when I was teaching, it just would be like, right, what does this mean, and what does that mean? And I'd just be like, tomorrow, or I just be like, right, okay, change the subject again. I don't know if that happens with people with brain injury.
Well, you might find that they flit from, so they might just flit from one thing to the next. Yeah. So it's, and they're very distractible. So they might be distractible what's going on outside of the window, or somebody might do something and then they're thinking about, start talking about what they did yesterday, or something that's worrying them. So you might see that it's difficult for them to stay on task and stay on topic. I sound like a teacher to my kids at school. Stay on task, stay on topic. So they might appear very forgetful. So often people say they've got memory problems, but it might not be their memory per se, it might be their attention that's difficult for them. You might find that they have difficulty learning, and difficulty learning new tasks. We already talked about losing track during a task. So you may find that they are slow, which is kind of an unexpected thing, but somebody might just be a lot slower in what they're doing. Not noticing their mistakes, so having poor attention to detail. So they might not notice when they've got things wrong. So they might have poor awareness of the environment around them, so they might not be attending to things that are happening within the environment, obstacles or things that they have to navigate. So directed attention fatigue is that where you've got somebody trying to do something quite complicated mentally, and they're having to filter out lots of background information. And when somebody fatigues with that, it's when you're revising for something, and your flatmate has decided they're going to play their music full blast, and you're trying really hard to understand the concept, then you find that you get quite ratty and irritable, and that's part of the directed attention fatigue. This is something you'll find. So what would that mean? I've given you some tips already, but in terms of, if you were organising physiotherapy for somebody, what does that kind of direct you to think about? What might you do slightly differently? Or what would you need to think about if someone's got attention difficulties?
If you're on a wall, don't realise noise and take them away.
Yeah, so find a quiet space to work with them. Yeah.
Decluttered space. So it's, again, with the concept you're saying before, so there's not any visual distractions. And also that you're not going to be interrupted by other people coming in.
Yeah. That's hard. If you're in the community, that can be quite a difficult thing to do.
Yeah. You can do something fun and interactive so they don't get bored easily. Because if they get bored, if they don't know exactly what the purpose of what they're doing is, you need to engage them so that they have fun, so that even if they don't know what they're doing, they don't mind interacting.
Yeah. So if it's fun or something that's meaningful for them, or they can understand the purpose of what you're trying to do. What else? About time. What
Just give yourself more time to do things, and maybe give them more time to process what you said as well.
Yeah, so think about how much time you allocate them for understanding the things you're talking about. also think about how much time you're going to work with them for that particular day. So being aware that maybe shorter periods might be more beneficial. Consider the time of day. So if attention is very susceptible to things like fatigue, you might find that actually they're better able to work with you when they're less fatigued. So there might be times of the day that are better for them. So you might be working in that sort of way. We'll talk about information in a moment. We get to processing. We'll have a short break in about 5 minutes. Is that right? Perception is massive and complex, and I'm not going to talk lots and lots about perception because there are all sorts of different perceptual difficulties that people might present with. These are a few. So, figure ground is the difficulty telling the foreground from the background. Yeah? So that's an example of kind of figure ground perception. So, do you see a vase or do you see two faces? Right? So it's like you're using your figure ground in order to make sense of that image. And things like figure ground and depth perception can become really important with people's movement. Yeah? So if someone has impaired depth perception, then you find that they're going to have more difficulty with steps and stairs, they're going to have difficulties with curbs, uneven ground, because their visual information, this is all about visual perception, the visual information is confusing in terms of the sensory input that they're getting. And things like kind of visual spatial skills, recognising how far away things are, recognising the speed at which objects are travelling. When might that cause a difficulty?
Crossing the road.
Yeah. So things like crossing the road. So that's kind of having a good awareness of someone's perceptual skills, because it will impact on their mobility and their safety if they're having those sorts of difficulties. And again, the same sorts of strategies really are around keeping the environment simple. If they're using, in OT we often talk about trying to change colour of the foreground and the background. So, if you've got a white Formica worktop in the kitchen, they've got white plates and a white cup, then it's quite difficult for them to find things. So you might start to get them to think about, well, maybe we'll change the colours of the cups, or maybe you just put a coloured tray down so that they can actually see the difference between the things that they're using. Trying to find things in the drawer, again, so you might look at how they've organised their clothes or how they're organising the cutlery and the crockery so they can actually see, detect things, because they might have difficulty distinguishing items from each other. And information processing, we talk about speed, capacity and control. So this is really, the speed is how much information will be taken in and processed. The capacity is how much can they manage at any one time. And control, how can they direct and organise their information processing capacity. So what you might find is that people can't take fast information, so you need to slow down in the information that you're giving them. And you might find that there's a limit to how much they can take on board at any one time. And alongside of that, it may be that they're better with visual information as opposed to verbal or written information. So it's a good idea to work with a neuropsychologist to get a sense of how does this person take in the information and what are their strengths and what are their weaknesses, so that I know how I might best facilitate their understanding of what it is I'm trying to do. And if you're giving them any sort of follow-on information, written information, thinking about actually what's the format that might need to be in, and how do I structure that so that they're able to kind of process it and able to understand it. Okay. Before we get on to memory, should we just have a quick 10-minute comfort break, stretch legs, get your attention mechanisms going again. Okay, so we're coming to the end of our run through cognition. It's just going to slightly get more complicated. So we looked at Simon. You could see that he had memory problems. He couldn't remember whether his mum had come. How did you find your way here? And yet she's been visiting every day. So he couldn't remember. That's what was happening with her. The memory is quite complex. We're going to simplify it massively into these two categories, and that is kind of explicit memory and implicit memory, and there's a good reason why I've split it into those two categories. They're not my categorisation, that is the way we think about them, but they are more complex. So explicit memory, just think of it as in terms of it's kind of the memory that you can express. It's your memory for facts and events, directions, routes. We can talk about kind of factual, and we talk about episodic memory, which is kind of, what did you have for breakfast this morning? Can you remember where you spent your 18th birthday? Those sorts of memories. And they can be very easily disrupted by injury. And obviously, people have got attention difficulties, they're not coding, so you might have more difficulties with the kind of factual remembering of things. The implicit memory is the stuff that we're not conscious of. So we talk about procedural memory, which is about your knowledge of how to do things. So this is your knowledge of riding a bike, driving a car, those sorts of things that you're doing it automatically and you don't have to think about how you do that. And the thing about implicit memory and procedural memory is that even if people have severe memory impairments, their knowledge of how to do things might still be intact. So I haven't got the video today, but there is a lovely video on YouTube about a guy who has Korsakoff syndrome, which is kind of an alcohol-related dementia. And he was a conductor and a musician. And he can't retain memory for more than 2 minutes at the most. So by the time you started a sentence, he's forgotten, and you finished it, he's forgotten the beginning of the sentence. And he's kind of trapped in time. His long-term memories are intact up until when the children were small, but he can't remember anything from the last 20 years. So he's continually doesn't recognise his children because he sees them as babies, but they're actually fully grown, and he can't hold that information, and he can't lay down those memories. But you put him in front of a piano, and he can sit and play the piano and play very complex pieces. And there's a clip where they take him to go and conduct an orchestra, and he can do that because it's procedural memory. It's not memory for facts. But the next day he's got no recollection of having done that. So procedural memory and implicit memory. So people can still do things even if their explicit memory is impaired. And there's a technique called errorless learning, which accesses directly implicit memory. Has anybody come across errorless learning before? If you've worked with learning disability or with children, you might have come across this. So the principle of errorless learning is that you teach someone how to do something, lots and lots of repetition. You use backward chaining. You come across that idea? So you break it down into the component parts and you cue all the way through, except for the very last step. Because what you're trying to do is you don't allow them to make mistakes. So mistakes interfere with the learning process. So if you can get someone to repeat something over and over again, do it without making mistakes, and use lots of cues to facilitate their learning, then you can improve their performance in whatever you're doing. So obviously it's not going to be being able to catch the right bus, because that's it's not the same thing over and over again. But we often, OTs use this sort of thing in terms of teaching people to wash and dress themselves or shower, or those sorts of kind of functional everyday activities. So there might be things when you're working in the specialist unit where errorless learning would be a useful technique to use with the other therapists when people have severe memory impairment. So different kinds of memory as well that you'll come across. We talk about amnesia. We have retrograde amnesia and anterograde amnesia. Retrograde is the loss of memory up until the event. And that could be from minutes to, as one guy I worked with who was assaulted and had a severe brain injury, and he lost nearly 10 years. He was 18, so he could remember up until the age of 8, and then he couldn't remember anything from the age of 8 until he was 18. And then he was starting to lay down memories slowly after the event. Anterograde amnesia is the period of time where people are unable to form new memories after their brain injury. So it took him about 6 months to start to be able to kind of recall and develop new memories. And slowly he filled in the patches. You know, his family brought in photos, they told him stories of all the things that had happened, and he could gradually start to, you know, whether he was laying down new memories or recovering old memories was difficult to determine. So those can be quite disabling. But anterograde amnesia, if someone is still in a stage of anterograde amnesia, they're not going to remember what you've done. They might not even remember seeing you, or who you are. So, and that can happen for a few days, it could take weeks, and in worst case scenarios, it takes months or it never returns. So obviously if people have got memory problems, the first thing you're going to notice is they could be forgetful. Yeah? But they might, you know, they might not actually turn up for, if you're doing community work or outpatients, might not turn up for appointments. They might get muddled about what it is they're supposed to be doing when. Quite often in a specialist unit, we work very hard at trying to get people to follow a schedule and a routine. So, you know, everything will be slotted in. Come into this route, this is when you come down to the gym. So they might not do that for a while. It might take them a while to be able to do that unprompted. So you might need to prompt them to do things. Difficulty learning, losing things, forgetting general knowledge and time-related information about themselves. So those sorts of things are less important. But for you, it's going to be, they might not know what it is they're working on, they might not remember what their goals were with you, they might not remember what you did yesterday, or they might remember who you are. So it's kind of that constant, you might need to constantly reinforce the information that you've given somebody. And then the last bit of that triangle was executive functions. And again, this is quite a simple way of looking at them. Executive functions break down into these parts. So the first is response inhibition, and my favourite way of describing this is the "did you spill my pint" scenario. So it's somebody is in a bar and someone bumps into them and spills their drink, and they're perfectly sober and in a good mood. They'll probably just go, "Oh, that's fine. It's fine. It's okay." When they've had a few drinks, someone bumps into them and spills their pint. It changes into, "Did you spill my pint?" Their kind of response becomes more aggressive. And they might actually even want to hit the other person. Now, response inhibition is that process where you might think you want to do something, but you actually stop yourself from doing it. Yeah? Some people are better at it than others. So, it's a thing you might want to say, but you don't say it. And that's your executive function kicking in. People have problems with executive function, they can't inhibit their responses in the same sort of way. So you find that we talk about disinhibition. People seem to be very impulsive, so they may have real safety issues. The gentleman that I talked to you about, who rode his bike, fell off, jumped into the swimming pool, had a few issues with inhibition. So they might be sexually disinhibited. So it's being aware of how they might respond to you, particularly if you're kind of very up close and personal, which is what often you may be doing with someone when you're in a physiotherapy session. I can remember the psychologist we were in London, and she was taking him to another hospital for a lecture because he'd agreed to sort of be her guinea pig and support her lecture and demonstrate some of his skills and difficulties. And she said they were crossing, it was by Queen Square, they were crossing the road, and he just ran into the road in front of the traffic and the zebra crossing threw his arms out and shouted to the traffic, "Stop, there's a psychologist crossing." and that was the way that he was. He was very, but actually it was quite dangerous to run out into a busy zebra crossing in the middle of London. But that's kind of his response inhibition wasn't brilliant. It got better over time, but he wasn't the safest of people to be around. Initiation, so the ability to get things started, and we also kind of talk about volition, so motivation. And sometimes what you find is, I'll be repeating the next step, what you find is that people have difficulty initiating things. And they may appear to be very unmotivated and very apathetic. And actually they've got dysexecutive problems. Yeah. So again, this is the sort of person that gets discharged quickly because they're difficult, they feel like it's like they're not interested. But it might not be that they're not interested or motivated, it might be a consequence of their brain injury. Difficulty planning, that's what the doctor said about Simon on the video. So you'll notice these things in an inpatient setting. There are lots of environmental cues, so your planning and scheduling performance of your average inpatient is quite limited. You see these things much more when they get out into the community. So if you're working in a community setting, these are when things will really start to impact on somebody's ability to engage in rehab. So again, organisation of time, understanding what they need to do when, where they've got to be, how they're going to get there, how long it's going to take them to get there. Mental flexibility, so people might appear to be quite concrete in the way that they're thinking about things. It's quite difficult to shift them from one way of thinking into another. And self-awareness, so the ability to understand their intellect, how their cognition works, the impact of their deficits on their performance, how it's going to affect them when they're about to do something, and how it's affecting them during the task. So we talk about emergent awareness. So that's when they've, just burnt themselves doing something in the kitchen if they're with an OT, as opposed to anticipating, so understanding how long will it take me to do this and how am I going to feel about it. So it might be, people have issues with fatigue and they have issues with self-awareness, that they don't make allowances for their fatigue levels. So these are also called metacognitive skills. So the sorts of things you'll see, we talked about apathy and impulsivity. People can present with this lack of social concern for others. So, some of the older textbooks talk about pseudo-psychopathy, pseudo-depression. People might present as if they're very depressed and quite flat and demotivated. Or they may be quite almost psychopathic in that they have a complete lack of concern for other people's feelings, emotions, become very kind of self-centered in what they want to do. Have poor judgment, so these where the safety issues might need to. And the sorts of judgments you might find, there's a gentleman that we assessed who discharged himself. He'd been a victim of an assault with a crowbar. And he'd had major reconstructive surgery. There were lots of skull splinters in his brain, and he had quite a big chunk of his temporal lobe taken away. The scans are amazing, really. He discharged himself 2 weeks after the surgery. So it's a young man, serious brain injury, massive surgery, sent himself home. So we picked him up in the community, and I remember assessing him, and he was, I'm fine. He was really cheerful, really happy. There's nothing wrong. Honestly, I've made a great recovery. Nothing wrong with me. I've really got to go because I've got to get back to work. It's like, what work are you doing? I'm a HGV driver. So he was just going to go and get in his truck and do a long distance drive 2 weeks after brain surgery, which was illegal because his insurance, everything would have been invalid, his safety issues. He had such little awareness of the difficulties that he actually had because of his brain injury. So the poor judgment can be quite significant. The other sorts of things, people I've worked with is where they've had issues with alcohol before the brain injury, and then any control they had over their alcohol and their drinking has gone out the window. So suddenly you find somebody who's drinking around the clock, 24 hours, left the family homes, taken up with some drinking buddies, and that could be quite devastating for the family and very difficult to manage as well. So with dysexecutive syndrome, often you find that it's things like work and relationships and friendships that start to deteriorate, and it takes time. So you see these things emerging later on when people have been at home. But for you, it may just be that you're finding that somebody doesn't seem to be aware of what they're doing. They think that they're fine. They seem to make, unwise decisions. They're in a hurry to get back to where they wanted to be. They're not really engaging with you. Or alternatively, they seem to be depressed. They're apathetic. They don't seem to be able to do anything. If you tell them to do something, they'll do it for you. But if you leave them to their own devices, they just sit and they won't do anything at all. So what you find is that they might be all right in your session, but nothing happens outside of that. So they're not doing any of the other stuff you might set for them. So I rubbed it off our list, I realised, but if you go back to our original question, which was, what is it that you need to engage in therapy successfully? And it's all about that kind of learning process and learning from experience. So actually we need to be able to attend and understand. We need to be able to remember what it is we're doing. We need to be orientated in time, person and place. We need to have good self-awareness of what's happening to us and what is it around our deficits. We need to be able to plan, organise, initiate. We need to know when to stop, and we need to know how to get started with things as well. And so these are all things that can be affected by brain injury. But again, things like dementia will start to affect all of these as well. So we talked a little bit about these. If people have poor self-awareness, they're not going to set themselves realistic goals. They might not adopt your strategies. You might find they're more depressed and they're more anxious. They have more problems at work and they don't integrate back into the community very well, and they have more problems at home with the family as well as a result of issues around self-awareness. So for you, again, you might find that they're setting goals that are just not going to be possible. I remember going to this gentleman, he was Egyptian, and he said to me, what I really want to do is I want to get back to running. And I kind of looked at him and I thought, well, you're in your 50s, you've got a history of diabetes and heart disease. So I said, when were you last running? And he went, when I was in the army. I said, well, how long ago was that? He went, that was 20 years ago. Okay, like maybe after this, after a stroke, maybe running is not the most realistic goal at this particular moment in time. Kind of bring it back to something like being able to go to the local shop. He was all set to be headed back to when he was in the army all those years ago. He hadn't run for 20 years. So thinking about realistic goals, and then do they actually cooperate with you and do what you've asked them to do? So for us, what can we do? As OTs, we do a lot of assessment, and a lot of these are really through interviews and observations. And there are things like, I'll pass these around, I think I've got enough for one each. This is a self-awareness of deficits interview. You don't have to do anything as formally, but you could just be asking them about their perception of their performance. Some of the interesting things about awareness is that if you keep tapping into awareness, if you keep questioning them and getting them to reflect, there is some evidence that you could start to shift and increase their awareness. Not for everybody, but for some people. So when you're working with somebody and you start to think, they don't have any insight, or their insight is limited, you have to think about, well, what do I mean by that, and where is it that their insight is affected? What have I noticed? And then it's a matter of kind of constantly questioning them. So before you get them to do something, you might get them to tell you How do you think this is going to be? How difficult do you think you're going to find this? Are there any problems that you might anticipate when you're doing this? So get them to think about what they're about to do, and then afterwards get them to reflect back to you, how do you think that went? Yeah? And if there's something that went wrong, ask them, you know, what do you think happened here? You know, is there another way that you could do that? How would you do it differently next time? So sort of kind of getting them to constantly think through, reflect on what they thought was going to happen, what actually happened, and how they might make that different. And the key to this is if you find that the person like Simon, you know, when she interviewed him and she said, how do you think that went? I thought that was fine. Was it fine? His little trip around the supermarket? If she hadn't been there, would he have even found the supermarket? Probably not. So he goes, it's fine. But it's not fine, is it? So she's questioning him, and he's still at that point, he's saying, oh, it's okay. And if you're working with somebody who continually isn't able to start reflecting, then it cues you into the idea that this person is going to need compensatory stuff. They're going to need someone else around or something else around to do it, because they're not going to be able to do it for themselves completely independently. If people have very poor awareness, then that has a major implication for them when they go home. So try and think about when their awareness is affecting them and how it's affecting them, and constantly keep questioning them. The other thing you can do is, when they're practicing their tasks, very easy often do tasks, you might do a whole range of things, get them to feedback on how they think it went, and you give them feedback as well. And you might use things like video feedback sensitively. So you might use video feedback so they can look at their own performance and whatever it is you get them to do and see what was happening there. We often use things like diaries as well to try and get them to reflect on the day and record what went wrong and what went well. And then you might do things like planned risk taking. So the client I worked with who kept getting lost, when she was an inpatient, they had done quite a lot of work with her on her kind of community mobility, not just finding a way around, but managing different kinds of ground, crossing roads and those sorts of things. So they had a session where they finally decided they were going to let her go on her own and where she was going to see what would happen with her. It's sort of a planned risk taking. She got lost, but they did find her again. So that you might consciously be deciding to do that with somebody. Let's see what happens with this particular issue. I talked a bit about mental fatigue. So the only key thing about this is that when you're working with somebody, recognising that mental fatigue, they might become more clumsy. They may start slurring their speech, and quite often they won't tell you that they're tired because they don't know that they're tired. So when you're working with somebody with brain injury, you need to be on the lookout for their fatigue, because by the time they tell you they're tired, it's too late. They've hit the wall and they're done. There's nothing they can do about it. So look for increasing irritability with them. Look for signs that their attention is deteriorating, and look for, they might start to stumble a bit more, or their movement starts to deteriorate, and those are the signs that they need a break. When somebody's that fatigued, usually the only thing that works is going to bed for however many hours it takes for them to kind of recharge. So fatigue becomes a real issue actually in the rehab process. So in OT, we'll use a number of different approaches. Hopefully the OT next week will talk about some of these. But quite often we use compensatory approaches, so we do a lot of task and environment adaptation. And it may be that this is a temporary thing. What we try to do is match the task and the environment to the person's skills so that you get the just right challenge. So it may be that we grade the environment in a way to enable them to do something successfully, and then gradually increase the complexity of the task or the difficulty of the environment to increase the challenge for the person. And it's something that you might, you'll probably do as well within your therapy, but be more cognizant of the fact that you might need to manipulate the environment more to match the person's needs. We do a lot of functional work, which is about learning from experience, so trying to do real life performance of tasks. One of the interesting things is if you're working with somebody in a very controlled environment and they're fine in that environment, you have to remember that when you get them outside, everything will change. So we had a guy with a brain injury who's lived in the community for many years and he kept falling. Effectively, his brain injury resulted in a hemiplegia and he got cognitive difficulties, but he'd been falling a lot. And so the physios worked with him in the gym and they really kind of improved his mobility and his balance, but every time he went outside he would fall. And when I took him, we actually took him to Camden because that's where he lived, so we went for a walk to Camden, somewhere that he went quite regularly, and what happened was he was able to walk on a nice flat surface when there weren't loads of people around him, but you put him on an uneven London street trying to navigate potholes and people coming towards him. He could not process the information fast enough, and so he would stumble and fall and trying to get out of somebody else's way. So thinking about the environment, often if you're working in inpatients or in a gym, it's very controlled, it's very safe, and it's not very stimulating. When you get them outside, it's going to be very different. So you need to take that extra step and see what they're like outside. I'm not going to talk about remedial approaches, but it's really kind of cognitive rehabilitation approaches that OTs use. So we might use kind of tabletop exercises or problem solving to work on different skills. And for you as a physio, I kind of thought these were the key things. The first biggest skill that you have or strength that you have is your therapeutic use of self. So it's how do you communicate, how do you break the information down, how do you relate to that person, what strategies do you use to motivate them if they're not very motivated. You need to be a bit of a social chameleon and adapt yourself to the person that you're working with. So one approach is not going to fit all. And sometimes you find that there is people who engage in more risk-taking behaviour are more likely to have head injuries. What that means is that when you're working with a head injury population, you're working with somebody who has a premorbid personality. So that personality may have made them more difficult to work with in terms of they're less compliant, they don't like routine, they don't like diaries, they don't like rules. And when you work in a rehab setting, it's very structured. There are lots of rules to follow, lots of things that are required of people to do. There are timetables, consequences if you don't do this and if you don't do that. And so within the population, people with brain injury, there'll be a core group who just don't engage, they just kind of fall through. And they need something different. They need people to understand that actually you can't they're not part of a treadmill, you can't just put them through the same thing that everybody else goes through and they'll be okay. So that's about trying to understand where the person is coming from and their background and how you might work with them in a different way. Talked a bit about the environment, so think about stimulation, challenge, and varying the environment. So you might need to think about actually how does somebody transfer their learning. If you've got cognitive difficulties, you don't generalise skills in the same way. So you need to facilitate their ability to generalise their learning from one place to another. So you might need to take that on board in your therapeutic approaches. Task modification, this comes into grading and adapting and scaffolding. So simplifying things where you need to, making them more complex to stretch and challenge someone. Scaffolding, do you know what I mean by scaffolding? You come across? It's an educational approach really, but it links into the stuff in a moment about zone of proximal development. So with scaffolding, you do the bits that the person can't do for themselves so that they're able to achieve the whole task. And then gradually you'll reduce your cueing, your assistance, your prompts, so that they can then do the task or whatever it is you're trying to get them to do independently. And we talked about timing, time of day, how long, how frequent, those are the kinds of things, how many breaks, thinking about those sorts of things to engage and facilitate somebody. Okay. Oh, this is difficult to see, isn't it? But this is based on an occupational therapy model, which is a dynamic cognitive rehabilitation model. And the reason I put it up here is because it just relates those parts together. So it's an OT model, so we talk about occupational performance, but in the end, if you're looking for efficiency and effectiveness of performance of whatever it is, that you need to think about the activity and the environment. You need to think about how the person is processing information, what's their self-awareness like, and you need to think about their personal context. So, the guy that I worked with who lost 8 years of his life, he had come from an unusual family home in Clapton, and his mum was in prison for smuggling cocaine, and he was living with his brother, and at the time of the assault, very disorganised, very unstructured. He spent most of his spare time selling mixtapes and things like that down at Brixton Market. That was how he kind of spent his time, and he liked to smoke a lot of marijuana. That was the other key thing that he liked to do with his time. So when I worked with him, on top of the fact that he had this profound memory difficulty and he had problems with his orientation, he also was somebody who was very disorganised and unstructured. So, trying to get him into a routine, he didn't want a routine because that's not how he functioned. Trying to get him to understand the implications of some of the aspects of his brain injury, it didn't match with his sort of lifestyle. So not everyone you meet, the personal context is going to be really key to how well they actually do, to a degree. So from this model, we look at the zone of proximal development. So we're trying to figure out how much capacity does somebody have to improve, and we're thinking about premorbid characteristics. So if somebody is low in confidence before the brain injury, they'll be low in confidence after. If they have a personality disorder before the brain injury, they'll still have it after the brain injury. I remember the consultant saying to me, just because somebody's disabled doesn't mean they're a nice person. So we had a lot of people that we worked with, because it was in inner London, who had very dubious sort of backgrounds, and that didn't change, because they'd had a brain injury. So you had to kind of take that sort of on board in terms of where they were coming from and what they were doing. You need to be able to link the learning with previous situations, so constantly keep doing that in your therapy sessions. And remember that familiar information is easier, so try to make things familiar for them. We talked about reduced self-awareness. I'm just skipping through, we're going to finish shortly. Try to enable their development through questioning. Consider the social and cultural environments as well. And this is the therapeutic use of self. It's about that skilled guiding, and that's what you need to do as a therapist. You need to be a skilled guider and facilitator of the person that you're working with. So structure your information, think about how much support you give them, think about the environment, and try and get a match between what they can do and what you're asking them to do. Investigate their perception of abilities. This just refers back to the self-awareness stuff that we talked about. And then when you're working with somebody, try and get them to think for themselves as much as you possibly can. So don't just leap in when someone is a bit stuck and tell them what the answer is. Just think about how you might cue somebody. If they're struggling with something, how are they going to problem solve that for themselves? So in OT, the example that I give is that if someone's in the kitchen and they're making themselves, we'll go back to tea and toast, and they're making tea and toast and the toast is starting to burn, you don't jump in and say, the toast is burning, what are you going to do about it? I need to know, have they noticed that the toast is burning first? So I might just ask them, is there anything happening at the moment in the kitchen that you need to think about? and just see if that's enough to cue them into the smell of the burning. If it isn't, you might say, can you smell something? If they still don't grasp that, you say, okay, I can smell burning, what do you think that might be? I know at this point the kitchen's on fire, so we kind of have to be a bit more careful. But so just really think about how you're cueing people so that you really are starting to get them to think this through for themselves. Don't just tell them the answer or even give them a big clue. Start early back, as far back as you can. And if something's not working, change it. Change it quickly to try and match their needs. So you need to be kind of constantly reflecting on what you're doing and flexible to the person's needs. Now, this is the comment that you made. I mean, in OT, we're very keen on meaningful activities, so try to make it meaningful to the person. Try to make what you're doing purposeful so that you can engage them and so that it's interesting. And for some people, it's easier. You know, they kind of get physio a bit more. It's not as they don't see it in quite the abstract way that they see occupational therapy, but still, you know, it's not, the things you do won't be for everybody, so you have to try and get them to see the reasons for it. And we talked about things like awareness training and evaluation. So these are tips that people can use to help with their processing. So you can get them to do things like self-talk. You come across the concept of self-talk? So it's an attention strategy. If someone's struggling to concentrate, get them to verbalise what they're doing out loud. And it focuses their attention on the task. You can eventually teach them to internalise that. So they might start off by talking through, now I'm going to do this, I have to do that, I'm going to open the door, put one foot through, whatever it is you're trying to get them to do. And then get them to internalise the voice. And that will help with their kind of attention. It's an attention strategy. Things like counting might also work, help with their pacing of the activity that they're doing or whatever it is. Mental rehearsal, again, get them to kind of think through the steps of what you're trying to get them to do before they actually do it. It will help focus them and help with their cognition. And then these sorts of things, the external strategies, you might just be using these to help them remember what they're doing. You know, what's the information you've given them? Right, make sure they've got it down in their diary. Make sure they've recorded the key points of what it is you want them to know and what they need to work on before you next see them. If they've got notebooks, you might choose to use timers if pacing and speed is an issue. You're trying to keep somebody focused and on track. So you might actually time somebody and get them to do something within a given space of time. And whatever it is you're doing, remember to vary it. Once they've got it, try varying it in different ways in different environments. And that's to support generalisation. So this is all OT, so I wouldn't worry too much about this, but the general point is that you want them to generalise their learning, so you need to get them to do it in different places, and you need to kind of change what you're doing with them to give them that flexibility. And at the end, what you're hoping for, aside from your physio goals, you're hoping that you've helped them to increase their awareness of the difficulties that they're having. Because if they've got increased awareness, then they have more choices about how to be successful. You should hope to see that they would have more activity levels. You know, they'd be doing more in their everyday life and have a healthier pattern. So they might be better able to cope with fatigue, for instance, if fatigue is an issue. You should hope that they have increased independence and that they're safer in whatever it is they're doing. But mostly what you'd be looking for is how satisfied they are with the way that they're doing things and with their performance. So what you're trying to do is achieve your physio goals but facilitate their cognition at the same time so that you can get a better outcome for the person. Has anybody got any thoughts or questions? Will we finish? We'll finish a little bit early teaching. Have you got any questions?
Yeah, I can't remember if you covered it. Is mental fatigue something you can improve by stressing?
There aren't any evidence-based interventions for mental fatigue at the moment, and we know that things like brain injury, it can last, some of the evidence is that people have it for 10 years after the original brain injury. A stroke, it can be around 3 years. So it's really about learning to live with it. So it's about people learning to pace, understand what triggers it, and what strategies they can apply to cope with it more than anything. There's been quite a lot of research trying to improve people's physical fitness and conditioning to see if that improves fatigue after brain injury and stroke. And it's kind of counterintuitive, but it doesn't seem to make much difference. Even though people can be quite unfit, you can improve their fitness, but their overall fatigue might not change. So really they need to learn how to live with it.
Can medical therapies help, like with concentration, for example?
In terms of like medications?
Yeah. I mean, that's the most obvious one, like, to me. Instantly, I'm just like, well, could probably give them some sort of stimulant,
Yeah, I mean, it doesn't...
People with ADHD, they take nootropic drugs, don't they? But if there's potential for plasticity and motor relearning, then
I mean, attention.
I don't know if there's any research into that.
Yeah, I haven't looked at. I know about them. They've looked at different drugs for fatigue, and there isn't anything that's particularly effective. For attention, the evidence base at the moment is that try to use compensatory strategies as much as possible. Attention is the one thing where there's some evidence that you could, if you do a graded approach of working on the different aspects of attention and gradually increasing the complexity, that people might start to change. You find that their attention changes quite dramatically in the first few months anyway. So if you work with somebody longer term, you'll see their attention difficulties are quite subtle. It's often in the early days. I'm not aware of anything, but I haven't looked explicitly at drugs, but I haven't come across any practice that people do.
But it might speed up the rehabilitation process.
Well, things like, for ADHD, they rely on that normal curve, don't they? The idea is if somebody's over-aroused, if you tip them up even more, they come back down again. And quite often, the problem with brain injury is that any arousal actually affects their function. So their processing capacity is very limited. So they fatigue very, very quickly. So it might just burn them out. Any other questions? I hope that you've got a few ideas. I think Ben's going to be looking at applying some of them in the seminar, so you might have the opportunity to think about what you might do differently. A lot of it isn't necessarily rocket science, but it's about awareness. It's having the awareness to understand what's going on with somebody, and knowing when to question would be the biggest thing, and who to go for help. Okay, thank you.